Hi, good evening, everyone, and welcome to our COVID-19 Community Town Hall. I'm Steve Elmer. I'm a member of the Health Research Institute here on our campus at Michigan Tech. I'll be joined shortly by my colleague and co-host, Dr. Kelly Kam. We'd like to welcome all of our viewers watching tonight on the Zoom webinar and all of our listeners tuning in on 97.7 The Wolf. It's great to have you back for another town hall. We also want to give a special welcome to any new viewers and listeners tuning in for the first time. Tonight's sponsors include the UP Health Systems Portage, along with Upper Peninsula Power Company, the MTech Smart Zone, and Aspirus. We want to thank all of our sponsors for helping make our radio and our Zoom broadcast here possible. Our Town Hall series is organized by the Health Research Institute here on our campus, along with additional support from the Center for Educational Outreach. I want to emphasize that the mission and the goal of the Health Research Institute is to promote and support health-focused research, education, and outreach here on our campus and in the community. Tonight is our fourth town hall in a series of several that we're having every Thursday evening right here on Zoom and on the radio. The overall goal of the series is to increase awareness about COVID-19, how it impacts your health, the health of your family, your friends, your neighbors, and our community at large. Each week we focus on a different COVID-19 related topic. Tonight we'll be focused on virus transmission, testing, tracing, and vaccines, all important topics in the news and in our community right now. If you happen to miss any of our previous topics, you can go to our website, mtu.edu/health-research, and you can download and watch the recorded versions. For example, the first week we learned about the role of public health in protecting our community. Then we moved on to how the community is putting emergency protocols in place to protect the community. And then last week we learned about the virus and how it impacts the individual human body and individual health. Next, I'd like to welcome and bring my colleague and co-host, Dr. Kelly Kam, who is our epidemiologist here on campus. So Kelly, welcome back. I hope you're ready for another town hall. We have an all-star lineup tonight and really a very interesting session, I think highly relevant to things that are going on here locally in the state and nationally. So Kelly, welcome back.
Thank you. I'm excited about the group we have tonight. So we have four speakers who are talking again about topics that are near and dear to my heart as an epidemiologist of the community mitigation procedures we can use to put in place to think about how we are able to stop and slow the spread of a disease where we don't have an easy treatment available for this. So this is, we're going back kind of to old school public health of thinking about how we have to understand how the virus is transmitted, both as the virus itself as well as our behaviors to help transmit the virus, as well as then what we do in terms of trying to understand who has the virus, what we can do to stop them from spreading it further, and how we can prevent it in the future.
Thanks, Kelly. Can you give us a preview of our speakers coming up tonight and who's all going to be here with us?
So we're going to start off with Dr. Cecile Perret, and Dr. Perret is an associate professor in the Mathematical Sciences Department here at Michigan Tech, and she's going to be talking about some modeling that they've done on looking at how we behave and how this virus is transmitted through the ways that we behave. Dr. Zach DeYoung is a family physician with Upper Great Lakes who's been instrumental in setting up our large-scale testing sites, both in our community and here at Michigan Tech. Madeline Morley is a Michigan Tech alum, and we're glad to have her back. She is an investigator working with the CDC Foundation in Detroit, one of our hard-hit areas in our state, and we'll be talking about the on-the-ground experiences that she's had as an on-the-ground public health investigator. And then we'll end with Dr. Karen Helt, who's both our director of the Research Institute, and she's also a professor in chemical engineering. I'm talking about how we're going to be able to deal with the vaccine. So there's not only the problem of developing the vaccine, but then we have to produce it and distribute it. We're excited to have all four of these speakers here tonight.
Okay, Kelly, well, thanks for that preview. Just a couple of other reminders. During the first half of the Zoom webinar and the radio broadcast tonight, the speakers will provide a short update that'll give the audience and the listeners time to formulate some thoughts and some questions. If you do have questions, we'll answer those during the second half of the town hall. There are two ways to send us questions. If you are on the radio, the best way is to email us at townhall2020@mtu.edu. If you're on the Zoom webinar watching, you can go to the bottom, click on the Q&A button, and type in your question there. And Kelly, I don't know about you, but we're scientists by training. And so we would just encourage and remind our viewers and listeners to focus on questions that are related to health, because we're not politicians, right?
Absolutely. And so we're interested to hear about all the ways that we can help mitigate things, regardless of the politics behind everything.
Okay. Well, let's get started with our first presenter tonight and speaker. We have Dr. Cecile Perret, who's an associate professor in the mathematics department here on campus. So Cecile, thank you for joining us and welcome to our town hall.
Thank you so much for inviting me. So I was asked to talk about transmission. And so in the spring, I got the chance to teach a class about the introduction to scientific simulations. And since COVID was starting to spread, we decided to focus on ways to model mathematically the spread of a contagious disease. And so we studied the common models, like the SIR models and things that you might have been aware of because they are in the news nowadays. And we started to see in the news and in mass vulgarization videos, the way that people think about how a disease is transmitted. And the way that people think about it is by imagining a bunch of tiny little dots that represent a person, and then one person is infected. Maybe it's a red dot among a bunch of black dots, and all of these dots are moving randomly. And when one dot is close enough to the red dot, then it becomes red too, and it kind of spreads like that outward. But it turns out that that's really reducing the problem, and it does not give the complete picture. And so in the class, what we decided to do was to actually try to be a bit more complex about what happens. So when you think about your day, so you have breakfast with your family maybe, and then everybody goes to their work or school, and then you interact with your colleagues or your students, and then after work you go to yoga or you go to the store and you interact with a whole new set of people. And then you go back to your family. So throughout the day, you see a certain number of different networks that you interact with. So you have the family network, and then you have maybe the business network or school network, and then you have the social network. And that's, most people have many more networks than that. But what we started with is to imagine a population for whom everybody has just 3 networks. Now, imagine that, you go to work and you see a colleague. Well, that person also has a family network, a business network, and a social network. And so, it's not at all, if somebody is infected, you cannot imagine that little red dot just infected people next to it, right? It's really that just imagine now all these dots together, and imagine that you're shaking them every time that networks that you change networks. So people go to school or to work. It's as if you took all these dots and you shook that box, right? Because you basically are performing a population shuffling. You're shuffling the population. And so we did a simulation of a spread of a disease like that using just 3 networks per person. And we saw that the spread is actually faster. And what we saw was that, in fact, the more networks you have, so the more shuffling you do, well, the faster the spread is. And then we started to think, well, what is the environment in which there is the most amount of shuffling, population shuffling? And the college campus came first because it turns out that in the United States, at least, it's not the same throughout the world. In the United States, the education system is set up so that people can choose their classes. And so from hour to hour, the population is going to shuffle every hour. And so that's what we realized, that's really a driver in a population. For it to spread the disease, you need this shuffling present. So we've heard a lot about social distancing. We've heard a lot about having a mask, but we haven't really heard much about shuffling the population and making sure that you stick with just a few networks. You try to limit your networks as much as possible. And in some circumstances, it's not possible to do. Like, when you go to college, it's impossible to limit your networks unless you take a class remotely. So what do? That really emphasizes the need for protecting yourself with a mask and with social distancing. So one thing that we have noticed now in the media is that, with data from Johns Hopkins, is that the college campuses become the hotspots. And that's exactly why. That's because of this population shuffling that is proper to a college campus. I think my 5 minutes are up.
Well, great. Thank you, Dr. Perret, for getting us started off here with the town hall. A quick question for you. Mm-hmm. What would you say is the biggest challenge when you're trying to model and forecast the spread of COVID-19? What's the single biggest challenge?
So the challenge when modeling this is, there are two types of diffusion. There's what we call the standard diffusion, which is, for example, you have an ink drop in water, right? Or a hot spot. You put a hot spot on a plate and you see the temperature rise around it, right? That's standard diffusion. And then there's something called the anomalous diffusion. And that's what happens when you spread the population like what I'm talking about. You shuffle the population. And that's what we are experiencing, this anomalous diffusion. Now, mathematically, that's a real nightmare, the anomalous diffusion, because the operators, the differential operators that are associated with anomalous diffusion deal with things like fractional derivatives. Just imagine having what is like a half of a derivative, right? So this is very difficult to compute. So computationally, modeling something like that is very difficult. So what people do is they take the standard diffusion and then they try to correct it using all kinds of other terms that kind of try to make it more correct, but intrinsically, deep down, it's actually not correct. It's based on wrong assumptions. So that's the most difficult part. So what you can do is do a simulation like what we did in class, which was quite simple. But to do the mathematical analysis of it, that is a nightmare.
Okay. Well, very interesting. I know there's going to be a few more questions about some of these assumptions that we hear about all the time. Mm-hmm. We'll save those for a little bit later. Okay. I want to keep us moving along. Our next presenter will be Dr. Zach DeYoung. Dr. DeYoung is a family and sports medicine physician with Upper Great Lakes Family Health Center here. So Dr. DeYoung, welcome to the town hall and thanks for being here tonight.
Thanks for having me on. For those of you who can see me, I'm wearing a mask today because I have someone in my home who is isolating with symptoms. So we're all trying to wear our masks in the house right now, but that's not what I'm here to talk about. So I've been invited, I guess, to talk about large scale testing. So I guess I'll kind of do this chronologically and talk about how we got where we are now. And the story kind of starts back in March when on spring break, there was somebody who came to the clinic and was worried that they had COVID. And they just kind of showed up as a walk-in appointment, which used to be how we did things. And they had several of the symptoms that were concerning for COVID. And so we had to figure out how to safely, evaluate this person and perform a test without exposing other patients or staff or other providers unnecessarily to a potential COVID infection. And so at that time, we had a special room set aside in the office where I could go in dressed up in PPE and do the test and then usher the patient out the side door so they didn't have to walk back to the waiting room. And so that was okay for a while. And that allowed me, every couple of days when somebody had concerns or concerning symptoms, I was able to do that. But the numbers started to increase, and I found that I wasn't able to keep up with my normal patient load because I had to keep stopping my day. And anytime somebody had a sore throat or a cough, put on a new set of PPE and wander into that room. And it got to be kind of disruptive for our clinic flow. So, at the time, the drive-up clinics were just beginning across the country. And so we were looking to begin to implement something like that. And our partners at the Western UP Health Department and over in Marquette County, they contacted Upper Great Lakes Health Center, and they wanted to collaborate with us on a way of implementing some drive-up testing in the Western and Central UP. So we set up a drive-up site at the Gates Tennis Center. Michigan Tech graciously allowed us to use that location for several months. And it worked very well for us because we were able to have people just roll up to a door, and our staff walked out there in the full PPE kit, performed the test, and sent the sample off. And about that time was when the Michigan Tech lab was beginning to get up and running. And so we were able to kind of send them a few of the first samples they did, which was nice to be involved in that and some of the first positives. So that kind of grew. We set up another sort of similar arrangement, which was more intermittent. It wasn't a daily thing. It was maybe every week over in Gwynn, south of Marquette. And then the health department came to us again and said that they wanted to be able to do some surveillance testing in the UP in areas where people might not be able to drive to the Gates Center because they have transportation or financial barriers that prevent them from showing up. So we had to invent a remote testing team. So they adopted the name the Covengers. And so we had 3 folks in a van who took some supplies, testing supplies and the PPE, and were able to set up in several communities in the Western and Central UP and do testing a couple times a week. And that went on for about 2.5 months. And we knew that we were getting closer to the time when the students would be returning. So we were having conversations with the university and with the health department about how we might do baseline testing for the students who are new arriving to campus, as well as returning students. And then the athletes from the university were rolling in kind of 10 here, 20 there, 30 here, 10 there. We wanted to test them as soon as they arrived as well. So we started doing that out of Gates, but we knew we weren't able to be there forever. So we made plans to have a testing site on campus. And so at this point, the kind of small scale testing we were doing at the Gates Center wasn't going to be amenable to what we needed to do for a larger number of people. We were thinking about 3,000 or 4,000 people in a month. So I borrowed some ideas from some of my colleagues in the Army. They have these influenza-like illness clinics that they've set up. And it's kind of the model now for doing drive-up or outdoor COVID-19 testing. So we were able to implement some of their ideas. They're kind of developed like in a mass cal sort of situation where if you're dealing with a biohazard of some kind, you have a hot zone for people that are exposed to the biological agent, okay? And then you have a warm zone where people who have been in the hot zone can go and transition into the cold zone where there's no exposure to anything that's been in the hot zone. So the students or folks from the community who needed to be testing would come in at one end, meet with the staff who checked them in for all the documentation and tracking purposes for the tests. And that happens in the cold zone. And then they'd move through a line into the hot zone to get their test and moved out quickly so that no one's lingering in the hot zone for any longer than they need to be to get the test. And so we had developed a pretty efficient I hesitate to say, factory line sort of setup, but we were able to move people through from point A to point B with really only a couple minutes. And achieving the task of getting the patient registered and their sample matched to them and making sure the spelling and the date of birth are correct and that the specimen's bagged the right way and put in the cooler the right way, and able to do, several hundred tests in a short period of time every day. So went from one test every couple of days to several hundred in a day, and we're continuing to do right now on average about 135, which honestly, I really like to be able to do more right now, but we have staffing challenges. We have actually issues right now with our staff. Some of them, like me, have family members who've tested positive for COVID or have COVID symptoms, or they have exposures. And so some of our staff are not able to be there right now, and we have limited capacity for that reason. It's just, it's tough to keep that thing running. So as we beef up our staffing levels and our resources to make sure we can meet the need in the community, it's been a real challenge. So one that we're trying to continue to meet. So it's a work in progress at this point still. And I don't see that it's settled into the final form yet. We won't really know what that looked like until we look back on it years later, I imagine. So continuing to develop and work on it with feedback from our partners at Michigan Tech and the health department and members of the community as well. So some successes and many learning opportunities every day.
Great. Dr. DeYoung, can you speak a little bit more to that collaboration between Upper Great Lakes, the Western UP Health Department, the university? How common is that across the country, just to start with that question?
Well, I think it's supposed to be very common, but I've learned in doing this that, each provider's office, if you got a private office somewhere, or even a small organization of clinics, or even a federally funded health center like us, they each have their own challenges. And so taking on the task of doing this testing, it might not be the case that everybody can rise to that challenge.
Okay.
Now, we have some motivated leaders, people who are very community minded. And even though we weren't really set up to do this to begin with, we were devoted to the project, felt it was very important, and we were going to do everything we can to make it happen. Again, everybody who's in on this project is working way beyond their capacity or their limits right now for their energy levels, their psychological health, their physical health, their time. But we're doing everything we can to get it done, and just because we believe in it so much, we think it's so important. This is our home. These students are important. We want people to do well. We want businesses to be able to function. But we want the health of the community, but health-wise, financially, to be good going forward. So we're working very hard to overcome the obstacles that COVID's thrown us this year.
There certainly have been a lot, Dr. DeYoung, and we definitely want to thank your entire team and collaborators for going above and beyond and helping keep our community safe and informed.
Thank you.
One quick follow-up question: can you just guide and direct people, if you're a community member, where do you go to get testing? If you're a student, we know about the COVID lab here. Do you go to Upper Great Lakes? Do you go to Portage, Aspirus, all three? And then secondly, if you're asymptomatic, can you still get a test? Okay,
so two great questions there. So as far as the first one goes, if you're a community member and you need a test, we are doing those currently at the Memorial Union building, the MUB, right now, while we look for a separate community test site.
Okay.
That has been one of those challenges, trying to find something that's going to be safe and accessible to folks in the community away from the MUB. But in the time being, Michigan Tech has allowed us to continue to use that site for community members as well. They park, walk up, and get a test. But like I said, we're looking to transition to something that's going to provide us the access for the folks in the community and the safety requirements for the staff performing the tests that we need. Because actually, we have had staff get sick, despite taking all the precautions and wearing PPE. So right now it's in the MUB. Yeah, and it's to be determined on the location for the next place. In regard to folks who are asymptomatic, anyone can absolutely get a test if they want. Unfortunately, well, okay, let me back up for a second. There has been rules out there, state and federal, encouraging everyone to get a test and making the statement that they should be free to the patient. And unfortunately, the insurance companies have not played ball with that all the time. And our organization cannot foot the bill, which would be several hundreds of thousands of dollars for all those tests if we were just to eat that cost. So if you are asymptomatic, a lot of the insurance companies up to recently have not been paying for those tests. I caught wind recently that there was a change and that the tests, the insurance companies now may start paying for those again because there's been a large pushback from leaders, political leaders. And so I don't know if that's changed yet, but my hope is that that does, because that financial barrier to getting tested when you're asymptomatic, that's a big one. So yeah, we're hoping that's overcome very soon.
Okay. Great, thank you, Dr. DeYoung. We're going to keep moving on to our next presenter here. I just want to take a quick minute for anybody who is just joining us on 97.7 The Wolf. We're here for our COVID-19 Community Town Hall. Our sponsors tonight include UP Health System Portage, Aspirus, the Upper Peninsula Power Company, and the MTech Smart Zone. If you do want to join us on the Zoom webinar, you can go over to thewolf.com and click on the link so you can see the video content here. Our next presenter is Miss Madeline Morley. Madeline is, as Dr. Cam mentioned, an alumnus of Michigan Tech University. Right now she works for the CDC Foundation as a disease investigator from downstate in the Detroit area. So Madeline, it's great to have you on the program. I'll just remind you to unmute your microphone here to get started, and welcome back virtually to campus.
Thanks so much for having me. I'm so excited to be here and to be able to be given the opportunity to present at my alma mater. Very proud Husky over here. So I am a communicable disease investigator with the CDC Foundation. And before I get started, I do just have to let you know that all thoughts and opinions that I mentioned today are my own and are not representative of my employer. And I am based in the Metro Detroit area. So I wanted to just walk you all through kind of what it looks like to investigate a COVID positive case, and from start to finish, including all of the contact tracing that goes into it as well. So across the state of Michigan, we use the Michigan Disease Surveillance System, and this is an online software system that is where any healthcare provider or lab or health department reports any type of infectious disease. So that could be COVID-19, Salmonella, Ebola, anything that could be contagious and spread from person to person. So when I receive a notification that there's a new COVID-19 case within my jurisdiction, it gets reassigned to me as the investigator. And then I have to go into the MDSS system, the Michigan Disease Surveillance System, and I look through their lab result, check to make sure that I know what kind of testing they received and when they were tested, and then I make the call to that patient or case. And I ask them an interview that lasts usually around 20 minutes. So I ask things about, were you ever hospitalized? What kind of symptoms have you had? What is your medical history? What kind of living situation are you in? And then I get kind of more into the investigative work where I ask about, have you ever been to any recent community gatherings or an event, or have you gone to any public places? And then I also ask about any recent travel. And I also do ask about who have you been around recently? What are your close contacts? And then I will ask you to provide me with their names and their phone numbers so that we can follow up with them and get them testing if they do need it. I did want to talk about some of the targets that the state has set for local health departments with their investigation efforts. So there are 4 different targets that the state wants us to meet as investigators of COVID-19 cases. And so the first one is they want us to make our first attempt at interviewing a case within 1 day of it being put into that disease surveillance system. The second target is they want us to actually be able to complete that interview within 1 day of it being referred into the disease surveillance system. And so that's really heavily reliant on the case or the patient picking up the phone when we call them. The third target that they want us to meet is they want us to be able to collect the names and phone numbers of our cases, again, within that 1 day period of when they've been reported into the system. And the fourth target is that they want us to be collecting the race and ethnicity data of any patient or case that tests positive within 7 days that they've been referred into our system. So then once we go through this investigation with the person that tests positive and we collect all of their contacts, those contacts get passed along to our contact tracing teams. And they are the ones that are giving the contacts a call, letting them know, hey, you've been identified as a close contact of someone that's tested positive for the virus. And these are the things that we need you to do with your quarantine requirements. We're able to provide them with any resources that they may need to be able to successfully complete their quarantine in the appropriate manner. And then we're also following up with them every single day of their quarantine period to go over any symptoms that they may be developing. And that way we're also able to refer them for testing in very much in a real-time manner. And this follow-up can occur either through an actual phone call with a contact tracer or by text, and it's just based on the preference and the availability of the local health department that that case falls within the jurisdiction of. So that's kind of just the flow of things, and happy to answer any questions.
So Madeline, thanks for starting us off here. Can you talk about the amount of time and effort that goes into contact tracing? I don't know if folks would quite appreciate this, if there's a handful of cases, if there's 50 or 500, and then when does contact tracing just become too much, I guess, if there's that much spread?
Yeah, so I do more of the investigation side of when people do test positive and not as much of the contact tracing, but I can tell you that I get cases that will give me anywhere from no contacts at all to over 20 contacts. And those phone calls probably take about 10 minutes per case. And then that's just the time that they're spending on the phone with that contact. And then after they get off the phone, they have to be documenting everything, sending it to the state, making sure that everything is meeting the criteria that the state wants us to meet. And I mean, depending on how experienced the contact tracer is, that could take anywhere from 10 minutes to maybe half an hour or more.
I'm going to ask one more question. This just came in. This community member is asking, in the future, will there be a contact tracing app that might assist the contact tracers or the community members?
I could definitely see that happening. I don't know of anything in the works right now, but I think that shift over into being able to do the symptoms review via text message is definitely a step in the right direction, making it easier both on the contact tracer and the contact that's being followed.
Okay. We're going to continue to move on our topic tonight as we get just about halfway through our COVID-19 town hall. We're focused on contact tracing, virus transmission, testing, and vaccines. I'm going to bring in my co-host Kelly Cam for just a little interim analysis here. We try to include a little myth buster. So Kelly, I know you prepared this for our viewers on the webinar and listeners on the radio. What's our myth buster here tonight?
So this one I thought as someone who is currently self-isolating because I've had symptoms, thinking about that one of the symptoms of COVID-19 is this loss of taste or smell. And so my husband eats a lot of hot peppers, and I found this one that the idea that hot peppers cannot cure or prevent COVID-19. So certainly having a healthy diet, as we heard from one of our previous webinars, a healthy diet, exercising, keeping yourself healthy is always good for your health, but specifically eating hot peppers is not going to help you cure or prevent getting COVID-19.
Okay, thank you, courtesy to Kelly, and this was from the World Health Organization. One more quick question for you, Kelly. We started to compile a list of helpful websites. We have this up for our viewers, but for our listeners on the radio, could you just hit the high points of some of the websites that we've learned through our contacts and former speakers that have really been helpful?
Sure. So there's always our government websites. So our local, our state, and our federal websites for our Western UP Health Department or your local jurisdiction of your health department, wherever you may be listening from, as well as the state of Michigan or any other state. And you can compare different states to states. There's quite a variety of information and ease of information that's available, as well as federally from the Centers for Disease Control and Prevention. Globally, World Health Organization, and then certainly there are many other institutes and universities that have resources such as Michigan Tech. Our Flex website does provide information about our testing and positive tests on our campus, as well as other universities like Johns Hopkins University's Coronavirus Resource Network, a resource site that has worldwide as well as down to the granular information that we showed last week on the county level information.
Okay, we appreciate the updates, Kelly. We'll check back with you in a little bit. Next, it's my pleasure to welcome back Dr. Karen Held. Dr. Held is the director of the Health Research Institute and a professor in chemical engineering. She was here to help us kick off our town hall series just a couple of weeks ago. So Dr. Held, welcome back, and we're looking forward to having you talk about vaccines here.
Sure, Steve. Thank you very much for inviting me. Glad to be back. And so if you want to go back to my first slide for me, please. Actually, the next one. Thank you. So I just want to talk a little bit about vaccines. And so the idea of a vaccine is that you take some part of a virus. So obviously SARS-CoV-2 is the virus that causes COVID-19. And so we want to try to find ways to create antibodies against that virus that is safe. And so we have traditional vaccines is where you can either take a virus and attenuate it. So we have live attenuated vaccines like MMR and chickenpox. And this is where you basically take the original virus and you grow it in cells that are not human. And then the virus then mutates slightly so that it will replicate in a different host than humans, but will still cause the antibody response that we need for the vaccine. And so this causes a very, very robust immune response. We have other vaccines that are called inactivated. And so inactivated vaccines are, examples are the flu or hepatitis A. And so this is where we take the original virus and then we inactivate it. We can heat treat it. Sometimes we put chemicals on it so that we cross-link it so that the capsid cannot open up. Or sometimes we can do other types of chemical treatments. And these inactivated vaccines, though, are still able to create this antibody response. And so that's the goal of these vaccines, to cause antibody response. Some vaccines, we haven't been able to figure out how to do a live attenuated or inactivated type of vaccine. And so we do subunits. So types of subunit vaccines are hepatitis B or HPV. And this is where we just take the one piece, usually the outside of the virus, and we use that as the vaccine. And so we've heard a lot about with the coronavirus that they have these spike proteins. And so one option to be creating vaccines for the coronavirus is to just then use the spike proteins, and that would be a subunit vaccine. And so these types of vaccines are considered traditional. We've been using them for many years as the design. And there are many other countries in the world that are looking towards creating coronavirus vaccines in these manners. However, the three leading vaccines currently in the United States in phase 3 trials do not use any of these traditional methods. So Steve, if you would change my slide for me. So a typical virus infection cycle is the virus will bind to a cell, and when it does, its goal is to replicate itself. And so to do that, it has to create a viral genome. So this is the RNA or DNA inside the virus. It has to create capsid proteins. And so this kind of encapsulates that genome. And then it has to create spike proteins. And so the virus will create this core of capsid proteins with viral genome inside of it, inside your cell. And then it goes to the cell surface and gets its crown of spike proteins. And so this is how a typical virus will infect a cell. And the reason I wanted to show this to you describe this process because the new vaccines are taking part of this infection cycle and making it so that you can safely have a very robust interaction in antibody response without having all of the other side effects of having the actual disease. So if you'll change the slide for me, Steve, you can see the parts that we are no longer doing. And so the three leading vaccines in the United States are either an RNA vaccine or a viral target vaccine. And all they're doing is they have the ability to make spike proteins, but they don't have the ability to make capsid proteins, and they don't have the ability to replicate the viral genome. And so what the goal of these is that the RNA or this encapsulated RNA will then inject into a cell and only create spike proteins. The spike proteins will go to your cell surface, and that is how you'll create your antibody response. And so it's quite different than the traditional vaccines. These types of vaccines have been used. There's many, many clinical trials, especially through the DoD, that have shown them to be safe and effective ways for vaccines. And so I'm really excited to see where vaccines go in the future, especially for the coronavirus, since there's so many different types of vaccines that are being created right now.
Thank you, Dr. Held. A quick question here. You mentioned a clinical trial. You also mentioned those phases. Can you just let our listeners and viewers know where are we and what are those different phases that the vaccine has to go through before it's ready to be mass produced and safely administered?
Absolutely. So there's three clinical phase trials that happen before you can release any drug or vaccine. So phase one is a safety process. So healthy volunteers are injected with your drug that you're testing, and then they look for the safety profile. What are the side effects? They also will often measure, for a vaccine, will measure your antibody response. These are usually very small numbers of people. And then your phase two trial is, again, a safety profile trial. So you are injecting a larger number of people, and you are observing more things than, so making sure both for side effects, but then measuring more things that's going on within their body to be able to understand that. And then we are currently have three different three different vaccines currently in phase three. Phase three is the largest trial. This is where we're actually testing not only safety, but efficacy. And so we, basically what happens with a vaccine trial, and the reason we don't know when the vaccine trial is going to end is because we don't know, we have to wait for so many people to actually get the disease before you can finish a vaccine trial. So if you are doing a heart medication, you know you need to observe your patients for 6 months. When you're doing a vaccine trial, you will dose half of the patients with a placebo or just salt water, and you will dose half of them with your vaccine. And the doctors and the patients do not know which one they received. They have statistically determined before the vaccine trial starts how many people need to come down with the disease before they can then release if they had the vaccine or not. And so that number has been determined for each trial. And so now we have to sit and wait for that many people to come down with COVID-19 before we can release the trial. And then we will then see if the people had the vaccine or not, and then they will be able to analyze that. The one reason that we can speed up these trials compared to typical diseases, though, is that we know the people that are high risk to get COVID-19. And so we can then focus our trial participants to that area. It's unethical. You can't dose somebody with COVID-19 So in some trials, this could take years, but that's why we think it could be much faster with this disease because it is so rampant in many areas in the United States.
Okay. Thanks for that explanation, Dr. Helt. We're going to continue on with questions to the entire panel now. I'm going to start with a question from a community member, again, open to the panel, and I want to start with Dr. DeYoung to get this question, start with our answer here. So in general, this community member is asking for some clarification about how the virus is transmitted. They're talking about, is it through respiratory droplets? Is it by touching surfaces? Or more recently in the news, is it the aerosol or those smaller particles suspended in the air? So Dr. DeYoung, could you start with some clarification for this question?
Well, I'd love to, but I'm not sure I can give a firm answer right now because there's an ongoing and very hot debate about that topic. I think that I'm starting to fall in the airborne camp myself, but currently I think the consensus is that it's still a droplet-borne infection. So I'm wearing this mask here, which doesn't protect me very well against things that are airborne. If I wanted more protection against something like that, I'd have to wear an N95 mask. But right now we're proceeding as though it is droplet, and I'm waiting for the weight of evidence to tell us which way we're going. So I think, again, people there's strong feelings about this in many people in the community. Right now I'm kind of on the fence because I'm waiting for the final say. So yeah, that said, we're still proceeding as though it's droplet, considering the possibility it may be airborne. And yeah, we are still encouraging people to absolutely protect themselves against the threat of infection from touching something inadvertently. So if you're caring for someone who might be sick, having them make sure that if they can, clean up with a EPA registered household cleaner. In the clinic, we use those special wipes to clean off all the horizontal surfaces and high touch surfaces. Cleaning your high touch surfaces around your house often, or if you share a residence with somebody else, that's a good idea as well. And of course, frequent hand washing with soap and water. And then if you can't do that, the alcohol-based hand sanitizer, as long as it's more than 60%. I'm probably beating a dead horse with all of that. We all know that by now, but that doesn't hurt. It probably goes the extra mile. It's
important to reinforce those messages. And I was going to ask Dr. Helt, could you comment, on the surface, how long does the virus present itself on a surface, thinking if you can pick it up from touching something? Could you comment on that?
So the length of time that a virus will last on a surface depends on the surface. So when we have copper or stainless steel or things that are very easy to clean and are also have a little bit of antimicrobial, then it may last just a few hours. Sometimes if you have something that's more able to soak in, paper, there was a paper out very early in the pandemic showing that paper will last several days, and plastics will last up to about 3 days. So that appears to be depends on the surface, how long the virus will last.
Okay, thank you. Next question that came in here is for Dr. Pire in our math department here. You talked about the networks earlier on in your brief update. This question is asking, is it better to limit the size of your network or limit the number of networks that the person
Definitely,
has?
it's better to limit the number of networks. Absolutely. And in fact, that's what the bubbles idea is based on. If you have, if you can limit the number of networks that that you're in contact with, so that they remain, so that to networks that you have some confidence that they are safe, and everybody does that, let's say, then you're pretty sure that it's going to be safe, right?
Okay.
So by having more networks, you are raising the number of the uncertainty, basically.
Okay. Next question is for Madeline, who works at the CDC Foundation. So this question came in talking about contact tracing, and given the time, the effort, as you mentioned before, how likely is someone to comply with the contact tracer's recommendation of going to get tested or going into quarantine? Can you comment on that?
I can comment on it. We hope that it's very likely. You know, a lot of the work that we do as contact tracers and case investigators is really heavily reliant on how well the public is willing to comply with our recommendations. And at the end of the day, that is all that they are, is a very, very strong recommendation that's heavily rooted in the science that we hope everyone is listening to and understanding as best as we can explain it.
Okay. A vaccine question for Dr. Helt here. You mentioned those phases. When a vaccine is ready, how will it be delivered in the sense, will everybody get it at the same time? Will it go to critical healthcare workers? What can you tell us about how this might unfold, or maybe reflecting on other vaccines that have gone through this historically?
So the vaccines will be delivered definitely in different parts. One, just because manufacturing the number of doses that we need worldwide is going to be impossible to do in a very short period of time. And so the vaccine will be distributed first to the most critical people and then slowly work its way through the community. So it will not be available immediately for everybody.
Okay. A testing question has come in for Dr. DeYoung. The question here is talking about, what is the difference between a false negative, a false positive, and how accurate are the tests here, say locally, compared to other parts in the state or nationally?
Yeah, okay. So, well, a false negative is a test that you do that says negative but really wasn't. It was actually positive. And obviously a false positive would also be a test that says it's positive when it's not. So right now with the tests we have going on, we're talking about basically this PCR test, which we're doing right now at the lab with Michigan Tech, which has great sensitivity and it's very specific for this as well. So it's going to catch a large percentage of the folks who have COVID-19, and if it comes back positive, it's COVID-19. It's probably not something else. There are other tests that give you your answer a lot quicker. They're called point-of-care tests. They use a different biochemical mechanism to work. Those come back a lot quicker, like I said, but the sensitivity is a lot lower. They're going to catch a lot fewer tests. The third one is this antibody test. People have a lot of questions about antibody tests usually. And so the trouble with those is the false positives on those a lot of times, especially, previously we were in an area with very few cases. And so if you had an antibody test and it came back positive, chances are it was a false positive. And so we were encouraging people to get the PCR test instead, because that was answering the question we were asking at that time. The antibody test, even if it came back positive, it's a false positive probably. And if it was positive, so what? We don't know when you were sick, and it doesn't mean anything necessarily about your immunity going forward. So it really wasn't helping us answer any questions. It's just kind of satisfying our curiosity. So right now, moving forward, there may be a role for antibody testing going forward as we're trying to figure out, well, okay, who maybe is immune, who's not, who's been exposed. When we're thinking about things like vaccines, and after we give people a vaccine, for sure we'll want to know, for a lot of them, did the vaccine take, so to speak, and that's where those antibody tests are gonna play a role. So right now, the best test to answer the question about whether I'm sick is the PCR test. The point-of-care test does have specific uses, but the big one we're focusing on right now is the PCR testing.
Dr. Young, we're going to stick with you. One more testing question here. Talking about a lab test versus a quote-unquote rapid test, and even maybe something in the future as a home test. Can you provide some clarification on all these different types of tests that people are hearing about?
Yeah, so I think that's kind of partly what I was talking about with my last answer, actually. So the rapid tests would be more of those point-of-care tests I was talking about, otherwise known as antigen tests, and they have the lower sensitivity. Now, some of the manufacturers are getting better at the sensitivity for those tests, and as time goes on, I think that'll improve, but it's, anybody who gets a point-of-care test is probably going to want to have the lab, the test like they're doing at Michigan Tech's lab done as a backup to confirm that as well. So home testing, yeah, I suppose that might be coming someday. I don't know. I haven't seen or read anything about that, so I have to admit that I'm completely ignorant about that topic. I haven't thought about that at all.
Okay. Next question for the panel. We know that cases have gone up here locally and in the UP for sure. What is the most important message you want to communicate to our listeners and our viewers about just kind of where we're at currently? And we could start with, how about we'll start with Dr. Pire.
So to me, the most important thing is that everybody should do at least the very minimum they can. You know, wear your mask, social distance. You know, I was out today, you know, running with my dog, and people were not social distancing, and you know, it's so heartbreaking to see. So do the minimum you can. Do it.
Okay. Madeline, we'll move on to you next.
Yeah, I would say from my perspective as an investigator, answer your phone, especially if you don't recognize the number, even if you think it might be spam. I mean, maybe it is, but it might be me calling you. So make sure you're answering the phone, and also be truthful with your responses and be honest. The questions that we're asking are purely for the benefit of public health and to prevent this further spread of the disease and to prevent outbreaks from happening. And when we're not getting honest answers from the public, that it's not helping anything. So just being truthful and answering your phone.
Thank you, Madeline. Let's go to Dr. Helt next.
I would say as we start getting towards winter, that do your best to find a pod. I think we still have a long ways to go with this. It's not going to be ending anytime soon. And so we need to find some ways to socially create what we need as humans to survive this. And winter in the UP is hard, and we're not going to survive it just as our families in our own houses.
Thank you, Dr. Helt. And Dr. DeYoung, how about you?
Well, I guess what I would want to say is that I would encourage people to take the health of the whole community very seriously. And I bristle a little bit about comments that people make about, oh, well, this is only for old people or very sick people. You know, in my role as a sports medicine healthcare provider, I'm taking care of young, high performance athletes. And my job right now, half of my job is evaluating folks who've had COVID to make sure that they don't have the complications of that. One specific one called myocarditis, which is a potentially career-ending complication of COVID-19. So it does not just affect, you know, the elderly and the very sick. And I guess if you don't care about those people either, I don't know what to say to you. But I mean, we got to take it seriously for everyone, because it does affect young people as well. And you know, as we're seeing lately with the cases in the schools, it affects our children and their education too.
It does indeed, Dr. DeYoung. I want to, we're getting close to the end of the town hall here. I want to just thank all of our speakers tonight for their time, for the information that they're communicating. I think it's a great example of how public health officials, physicians, researchers, directors, folks that are really working hard here to protect the health of our community. So thank you to all of you that are doing such great work. We really appreciate it. I do need to recognize our sponsors here, UP Health System Portage, the MTech Smart Zone, Upper Peninsula Power Company, and Aspirus as well. I want to bring Kelly back in here. I know Kelly, you'd like to give a heads up for next week. We'll be on here Thursday at 7 p.m. What's our topic coming up next week as we move on from viruses, testing, tracing, and vaccines?
So we're going to move on to what happens in terms of hospitalization and acute care. So certainly we know that some people have mild disease, but some people have very severe disease. And so we're going to address what happens with hospitalization and acute care and how this is impacting our hospitals in terms of treating our patients.
Yep. And then Dr. DeYoung, I know he mentioned a little bit how it's impacting our schools here. Kelly, is there anything else that you can share as we're getting some news coming in during our webinar here just about cases here locally in schools?
Yes, so as everybody has discussed, we have had a huge increase lately in cases locally, and there is just news. So my children attend Houghton Portage Public Schools, and while we were on this webinar, we received, parents received a message from the superintendent of schools that Houghton Portage Township schools will be shutting down for 2 weeks beginning on Monday. And Hancock schools will also be shutting down. A notice went out to those parents that Hancock schools will also be shutting down. So, and this brings back, it's full circle to what everybody has been talking about here, that if we don't have the healthcare capacity, the testing capacity, the public health capacity for contact tracing and case interviews, that sometimes we do have to take a pause. And this is exactly what this is. It takes out, just as Dr. Prier was saying, it takes out one of those networks. So we're not mixing with the school network. We've got our home networks, and we hope that we can keep our home networks and our social networks small in those pods, as Dr. Help mentioned, so that we can catch up on our contact tracing and testing and make sure we understand where this is in our community and how we can stop it. And I'd like to just emphasize again what Madeline said with the contact tracing that I'm helping at Michigan Tech. We need everybody to answer their phones. We're all working from home now oftentimes, and so some things are coming from our personal cell phones. And so answering those calls will help us be able to figure out how we can stop this and keep track of everything and know that we're not putting more and more people in our entire community in danger of being sick with this.
As always, Kelly, thanks for your input during the town hall and more importantly, everything that you're doing here on our campus. I also want to give a special thanks to several people behind the scenes that are making helping create the town hall platform here as we wrap up. Lydia Lytle, Cody Kangas, Cassie Munoz, Jody Lehman, and many others. Thank you. We'll continue to provide the platform here to share the information that's coming out and what we know. So hopefully we'll see you next week on Thursday, 7 p.m. right here on the Zoom webinar and on 97.7 The Wolf. Have a great rest of your evening. Be healthy and stay safe. Thank you.